social determinants of health. He has been and is still very active in multiple community organizations, which goals are to address social determinants of health and decrease violence. So we are really honored to have Dr. Chen talking to us today, and I'm really excited to hear this presentation.
Thank you all. I'm blushing. And I'm going to apologize if I keep looking up because I have the clock right in front of me. We have a lot of content I'd like to go through. I apologize in advance for the overwhelming nature. And if you have questions and you want to type them in the chat, I'll do my best to be able to get to them if we have a little bit extra time at the end. Disclosures, I have a couple of research projects, but really I'm involved with a number of community initiatives for decreasing violence. And there are policy implications and relationships with this, and I want to make sure that I'm as fair and transparent as possible into what my position is and what drives the work that I do. And really, I would say a lot of us do here within the healthcare space, in the community space, and beyond. And so again, I'm just going to be flying through these slides. We'll start off with the definition per the World Health Organization. Violence is the intentional use of physical force or power, essentially to coerce. And this can take place on the individual level, on the group level, but ultimately it's defined as resulting in injury, death, psychological harm, maldevelopment, or deprivation. This is a very broad definition for violence, just like the WHO has a very broad definition for health, but I hope to illustrate how the scope of violence is broad. So before we get into the details of it, I'm going to start with a series of fast facts about gun violence. And the reason why this is really important is because there's so much shading that happens to our understanding of firearms and their intersection with people, human health, society, culture, that it's often difficult to tease apart what's perception and what are things that are observed realities. And so I'll do my best to go through these quickly to set a foundation for what we'll need to understand in interpreting other observations from the research literature. First of all, there are likely more guns than people in the United States of America. I'm going to repeat that again for effect. There are likely more guns than people in the United States of America. That said, ownership is concentrated such that not all households have guns. And in fact, a minority of households have guns. But that number has been increasing essentially since 2020. One could say that about 40% of households do have a firearm in it, or know someone that has a firearm within the household. More deaths occur by suicide for firearms than by homicide. This data here is depicted from 2020, though the numbers still stay within a few percentage points from year to year, 2020 being unfortunately a peak year in terms of gun violence in the United States. The reason, though, why more gun deaths occur by suicide than homicide is because most firearm assault injuries are actually survived. And this is something that is surprisingly difficult to tease apart in the epidemiological literature, what the true incidence is of firearm injuries in the United States. Not all injuries will present for healthcare, but the more serious ones tend to. And of those, again, still most firearm assault related injuries are survived. And you can see here in a fairly recent estimate from 2020 that depiction where you see the majority of suicide attempts that result in firearm injuries that present to the hospital are deaths eventually, whereas it's the opposite for homicide or assault injuries. Gun violence in the United States is very common. And this was a study done by the Kaiser Family Foundation that came out last year. And even though I spent a lot of time reading the literature and trying to get a sense of this, when I saw this, it still shocked me in terms of its distribution. This was a probability-based sample, but again, across the United States. And what they inferred here was that more than half of adults in the United States have experienced some kind of gun-related incident. Not only that, when it comes down to personally being threatened by a gun or having a family member that was killed by a gun, that's 1 in 5. This said, the experience of persons in the United States with gun violence is very much different based on demography, geography, socioeconomic status, and by those corollaries, race and ethnicity. And so kind of drilling down more into the study, if you look at those who have personally ever experienced any of the following, you see a higher proportion of those who are Black adults experiencing these than Hispanic or white adults. But when you look at how much of it is from witnessing someone being injured from a gun, that's probably the greatest explanation to that variation there. It's the witnessing of that, as well as to a degree the direct injury. And this speaks to the degree to which gun violence involves networks of people, relationships, and close communities. And we'll dive into that later. Again, and you can see that in the bottom half of this chart here, talking about family members who have experienced gun violence. This experience of gun violence then has an impact on choices we make in daily life. And some of these may be related to the mass media coverage of very highly publicized events. We think about the kind of mass murder-suicide events that occur, mass shootings where we're talking about dozens or more of people injured in a single incident. But the chronic toll of this on a day-to-day basis and on shootings that are on the order of 4 persons injured per shooting or less is still, again, skewed such that some demographic experiences more than others. And this is a very complicated topic that we'll start to try and pick away at here. But just observing it from this perspective here, in terms of how it impacts people on the day-to-day, and you look at who has been really forced to encounter this or who has changed their daily behaviors, one thing that's really notable here is who chooses to purchase a gun as a precaution to protect themselves, and who avoids large crowds or the contact they have with others in society. And here you just see in this slice and row that persons who are white are in this sample more likely to have purchased a gun in order to protect themselves from the possibility of gun violence as compared to Black or Hispanic populations. But that there is also differences in other behaviors here as well. For example, those that attend a gun safety class as related to this or practice shooting a gun, as well as looking at those avoiding large crowds such as festivals or bars or clubs. Also notes the differences in moving to a different neighborhood or city. And here, the disparity that's present among the Black population is really notable, and Hispanic as well. Even with this high prevalence of experiencing gun violence in some way through a social network or close family member or community or friend, even with that said, very rarely is gun violence talked about by those who are healthcare providers. And some of this has its roots in politics as well as proposed legislation. Some clinicians may remember proposed legislation that I think was initially enacted before it was overturned in Florida, saying that physicians and clinicians could not ask about firearm ownership in the house, or that this would potentially be a violation of the Second Amendment right. That said, this was overturned later in the courts by saying that to enact such legislation would be a violation of the First Amendment rights of clinicians, and also in the interest of their clinician-patient relationship. But that singular experience introduced a chilling effect into how clinicians then feel in terms of their confidence in being able to simply inquire about the presence of a gun in a household or a home. And while I can understand where there may be, room or concerns about political influence, even being able to talk about safe storage or protection in the home, which has been associated with decreased risk of firearm violent injury, either intentional or unintentional, still to this day, and again, going back to the survey, few people as surveyed in the general population say that a physician, a clinician, a healthcare provider has ever asked about guns in the household or any kind of conversation about that. It seems that pediatricians tend to do this more related to education, and also due to already in place screening methods that pediatricians talk about, like car seats or poisons or other things in the home, and where there's a natural launching point in being able to have that conversation. But even in that clinical scenario and context, it's still relatively rare. So when we talk about firearm injury, and speaking of pediatricians and counseling and things like that, we must recognize there are different types of firearm injuries. And so we need to be very careful and clear about which specific types we are talking about. And I think a lot of the confusion, a lot of the rhetorical flashpoints that occur come when we are not careful in this delineation, where we take issues related to one domain of firearm violence and we start mixing or importing them to others when that translation doesn't necessarily exist. So for example, we can break this down into three categories: unintentional, intrapersonal, and interpersonal. Right? So when we think about unintentional, we can think about, say, the toddler that fishes a gun out of the mom's purse, or someone who is elderly that has guns in the home but has progressive dementia and then has essentially access to that without otherwise intending to. So essentially unsafe storage here. We also think about intrapersonal, and so suicidality, self-harm is a form of violence, and it is intrapersonally directed. And so we can see how the death rate from suicide is high when a firearm is involved. But then we also can see how there may be a crossover here, where a mental illness may expose persons to firearm violence when it involves both intrapersonal and interpersonal violence. That said, I'm just going to put a sticking point here. I will say those with mental illness are far more likely to be a victim of violence than a perpetrator of violence. That's what's been established or at least surveyed in the literature. And I think it's worth saying because oftentimes we get a different media impression about that nationally. And then we talk about interpersonal violence. And here we have essentially two broad categories: assault and legal, assault being the majority of the encounters that come to the healthcare setting. And within assault, there are different forms. There's intimate partner violence, and then there is other assault. And even though I say other assault here, it is a very large category that often is then related to homicide, not from intimate partner or domestic violence. The thing is things cross over again to these categories. So the mass shooting events, as one example, often cross over between two. And many of those mass shooting events, the perpetrator there has had a history of intimate partner violence before. And so we find this very ambiguous nature sometimes to people when we're trying to come up with ways of thinking about or classifying or delineating mechanisms and risk factors and risk groups for firearm injury. But this is one way of thinking about and stratifying those things. Now, the fact guns are durable. What do I mean by that? This study in the New England Journal of Medicine was looking at handgun ownership and then risk for suicide over time. And what they found was the presence of the firearm in the home from essentially the time that it was first purchased up until really 10 years later had an enduring risk of increased risk of suicide throughout the time that it was present there, as far as they were able to confirm essentially handgun ownership. And so this is different because it's something that may literally just sit there. It may be in a locked box or not, and it may not otherwise be active. But when something happens or something changes, or when there is an access point that is available there, or there is an impulsive thing that is taken, then that suddenly can become a lethal mechanism in different ways, whether that's suicide or, again, homicide. So, and this is where it becomes tricky, because then these durable goods, so to speak, from economic terms, then can leak into the illicit market. And this is where, unfortunately, a lot of the risk as it relates to homicide comes from, and yet is probably the least understood in all of the pathways and mechanisms from what we get from gun ownership and possession to then where it causes an injury. And so how do guns flow from legal to illegal commerce? It is not through robbing gun shops. It is not through that point there. Almost certainly, or I would say in most cases, it starts off with someone that is a legitimate owner, or where a legitimate purchase happens. And then it goes through essentially these straw methods or private transactions or theft then entering into the illicit market. What proportion comes from which is not clear. It is difficult to estimate and calculate and track. And it's something that is really disturbing when we think about, again, the prevalence and the incidence of firearm injury in the United States. One could speculate that many of the break-ins into cars may be related to looking for something that has high cash value, such as actually a firearm and its value on the illicit market. And so again, we don't really know, though what we can infer are from things like this ATF report, the Department for Alcohol, Tobacco, and Firearms Use, from 2023. And this again was one of those studies where I kind of wasn't surprised, but was still shocked when I saw it. And in the study, one thing they looked at was what's called a time to crime. So what this is when there is a firearm recovered from the scene of a crime, and they trace it back to when it was first legally purchased. That is the time to crime. When did it transfer over from legitimate purchase and ownership into essentially illicit use? And in this time period that was studied from 2017 to 2021, nearly 25% of these guns that were recovered from a crime had a time to crime of less than 1 year, and 46% within 3 years or less. Right. And so things that change the flow and the traffic of firearms likely do have a very rapid translation into then homicide or attempted homicide and assault and injury. And this is not to say that this is like a common or typical for those that purchase firearms. Again, we saw there are more guns than people in the United States. And one thing that keeps striking me every time I look at the data is I wonder, why aren't there actually more injuries given the high prevalence and ownership of firearms in the United States? And there are protective factors as well as the ones that are risk factors. The focus here is on risk factors because these are things that are perhaps easier to modify, but they may tie into protective factors that can be strengthened as well. So what's the net effect of this? Well, 2020 essentially became this natural experiment where there was a historic surge in the number of firearms that were purchased in the United States, as well as social changes and a variety of things in terms of policing relationships with the community, the presence of policing, the presence of institutions in the community, both healthcare as well as nonprofit organizations, the presence of schools in the community, and the changes in all of these different factors and influences likely cumulatively related to this fact that you see here, which is that gun deaths, at least in 2020 and I believe 2021 as well, have become the leading cause of death for persons 1 to 20 years of age. The leading cause, okay? More so than motor vehicle crashes. However, this is primarily because of its involvement with adolescents. And so this is not as commonly actually the toddler to 4 years of age accidentally fishing the gun out of somebody's belongings, but likely more intentional access and use that takes place in adolescence and emerging adulthood. And this surge that took place in 2020, in addition to being historic, was also concentrated among populations that have had historically the highest rates. Young men and adolescents, those who are Black, and those who have worse poverty, these things often being tied together. And so what do we know about in Delaware specifically? So in Delaware, gun violence remains high. And so this policy assessment by RAND looked at different states and made a comparison in firearm deaths as compared to the United States at large. And so while Delaware may have a comparable number of firearm deaths as assessed here to the US at large, that's in part because there are fewer suicides that occur by firearm that are documented and reported, but a much higher firearm homicide rate. And so what is the kind of downstream impact of that? Well, it's concentrated in particular areas of the state. That needs to be understood carefully because larger population centers will have more people. And therefore, with more people, you may observe more frequency of an event happening, but whether that's because of a higher incidence rate needs to be assessed carefully. You can think about it similarly with motor vehicle accidents and crashes. That's a function of how much driving takes place and also who is driving and where they are driving to. So that said, when we look at some local data here, looking at adverse childhood experiences, and in this survey that was done looking specifically at factors such as parent served time in jail, death of a parent, unfair treatment due to race or ethnicity, and having been a victim or witness of neighborhood violence, some of these measures not classically measured in the original ACES study, we see a significantly higher rate in Delaware, according to the red arrows here, and in Wilmington City in particular. And you look here and you see increased, essentially, reported rate of extreme economic hardship in this study, as well as increased rates of death of a parent and being victim or witness of neighborhood violence. And we wonder then what that relationship might look like. And so we'll return to that in a minute, but this is a stunning fact that really deserves to be mentioned. In most Delaware shootings, no one is arrested. And so if you think about if you were to be injured by a firearm and the person who perpetrated this to you was not arrested, what guarantee do you have of your own personal safety from another incident occurring? And so these incidents are less likely to be from intimate partner or domestic violence, more in that other assault category. And it's an unnerving thing to think about from a personal perspective. And so when we think about that and we think about the risk factors that go into firearm exposure and injury, there's many different ways that we can begin to classify that. This is one method of doing that. And in the past couple of years, we've really seen a lot more recommendations for interventions, for research, and for approaches. And this one kind of takes the classic public health model and doing it, looking at things before the gun is fired, when the gun is fired, and after injury. And then intrinsic factors related to the host or to the agent itself, the physical environment, and the social environment. Some of these can be operated on the policy setting, some of these on interpersonal setting, some of these on the personal setting, some of these are from access, to firearms, and you can kind of go all over the map with this. What I've highlighted here in red are the ones that locally within the state of Delaware have begun to have some form of intervention taking place. Right, and so that includes substance use treatment, domestic violence screening, alcohol screening and brief intervention, stop the bleed bystander training, hospital violence intervention programs. You can kind of continue going down this list. How many of these are evidence-based? They all have some evidence basis to it, but then the implementation and the efficacy of it is where we really need to pay more attention, and that comes from investment. And so we'll get into that. And when we talk about investment, we talk about dollar amounts related to things. This was an estimate done of the cost of firearm violence in the state of Delaware. And based on this estimate, which was really extrapolated from national data, the estimate of direct healthcare costs was $10 million, essentially on a per annual basis. And that's a lot. The amount from pain and suffering and other cost is also very high, including lost income. And some of these can be subsidized or can be addressed through things like victims compensation programs, but nowhere near to the scale of what is seen here. So I hopefully have made the case that we need to know more about it, but there's been a historic lack and actually intentional underfunding, I would say, of firearm violence going back to the Dickey Amendment. That said, Senator Dickey has since come forward and said that that was not the intended result of prior policy things that took place, and has encouraged ongoing research and policy attention to gun violence. But looking at it historically in terms of how much is spent on research and how much is published related to gun violence compared to relative mortality, as we've seen, gun violence is underfunded and understudied. Some of the reasons to this is that assault data itself is very difficult to measure. It's siloed and it is inconsistent, both in definition as well as repeated measurements and identification. And so as an example, firearm assault data, on the one hand, yes, it is mandatorily reported on by health systems, and more severe injuries are likely to be more consistently reported in trauma registries. However, follow-up to that may be interrupted if the person enters into incarceration or with justice involvement. There were changes to ICD coding patterns from ICD-9 to ICD-10 that may have affected whether a firearm injury is classified as an assault or even actually as an unintentional injury. And this misclassification makes then retrospective data analysis much more complicated to do. This all existed prior to 2020 and was more complicated following 2020. And so, like I said, there's this historic rise in all of these firearm-related injuries in 2020. But then what happens when there is an observed decrease following it, which we did begin to observe in 2022, 2023, and hopefully into 2024? Is that because of regression to mean? Is that because of the restoration of public services? Is that because of the alleviation of other societal stressors? Is that because of a reduction in the new purchases of firearms and the way that transmits into the illicit market? It's very difficult to say. But what we do know when we go back through research, and including a study done in the city of Wilmington here in Delaware, what was found by the CDC when they did this investigation was that contact in the emergency department for assault or justice involvement was the most predictive of, in their end outcome, future arrest for violent firearm crime of cases reviewed in 2009 through 2014. And observations like this, as well as others, have led to future interventions such as hospital violence intervention programs, which I hope to touch on a bit later. But that's to say that there are these different factors that are there, that are present, and I hope to review some of the evidence behind these, but recognizing they take place on all of these different levels and intersection with all of these different institutions and sectors. So that includes healthcare, that includes policing and the justice system, the carceral state, education, nonprofit organizations, things that happen in the after-school community, the house level, the home level, the individual level, and again, other interpersonal relationships. So how do we begin to study and understand these? And a lot of the prior research has focused on transmission of violence. You can think of it as something that perpetuates or propagates from one person to another, and as such may be understood by studying network-based transmission. And so this epidemiologic review from 2016 looked at the studies that were out there with this concept in mind and found that having a perpetrator of violence in someone's network places all the others in that network at increased risk of victimization. Though the focus of that study was on intimate partner and partner violence. Close association was also associated with it. Exposure to violent perpetration. Again, you can see how having someone in your network that is exposed to or direct victim or perpetrator of violence is associated with increased risk of those same things happening to other people within the network. There are certain high-risk behaviors that increase the risk of that transmissibility, so to speak. Alcohol, substance use disorder, criminality, and delinquency as classically defined. And so it's given rise to this description of violence as a contagion, right? And so there had been talk about thinking about it like an infectious disease in terms of how it transmits and propagates between these social networks. And this kind of landmark study in 2017 modeled this across the city of Chicago. And what they found is that the most dense network was associated with the vast majority, 74% of gun violence episodes. Moreover, they could begin to predict or try to attribute that social contagion in terms of its risk to any given person if one individual was then known to have a new incident. And so, there's been a a lot more talk and phrasing of it as a contagion. The problem with this is then now you begin to describe people as having behaviors that are infectious. And that has this tendency to potentially worsen a lot of the stigma that's already present when we talk about firearm violence. And when I say that, then we need to really bookmark a moment here to talk about structural violence. And so we talked about violence and interpersonal violence as being something that is propagated from one individual to the other, but could also take place on the group level and on the system level. And when we talk about structural violence as originally described by Johann Galtung, going back here to, I think, I want to say the 60s, 1969, it recognizes that this cannot be separated. Interpersonal violence cannot be separated from the way in which systems and social structures kind of force that upon people in terms of that contact, right? We're talking about social contact and network and density, and foster the environment in which that occurs. That's a big statement, so I'm going to try and drill down into this a little bit more. This book, recently published, highly recommended by a colleague of mine, Dr. Yasser Payne down at University of Delaware, puts an even sharper point to this, talking about sites of resilience. And a part of his point here is that the structural violence and structural disinvestment that happens in communities, particularly Black urban communities, then itself leads to all these things that predispose towards violence, in part because then the forced adaptive behaviors for it result in things that are related to delinquency, are related to criminologic conceptions of things that are negative. So what do I mean by that? That was a lot of kind of hand waving. So for example, if you are in the education system and you have a 3rd grade reading level, but you are now in 6th grade, or you're in, say, 10th grade, and the state of Delaware doesn't have mandatory education beyond essentially 10th grade, and you no longer continue in the education system, and you do not have accessibility to work, what then becomes the readily accessible means of income for yourself or for your household? And that may involve essentially illicit drug dealing and transactions. And while that is criminologically typed, that is perhaps an expression of resilience. It is survival. It is providing for oneself and for one's family. And so you see how there are these structural elements that then essentially funnel people and systems and things towards these elements where people are in greater contact with things that increase their risk for being a victim or perpetrator of violence. Right, and so we look at this from a geographic basis. Here on the left is a map of Wilmington City and the distribution of different gun violence episodes, shootings, community violence exposures that occur in different neighborhoods here. And then kind of overlaid with that on the right side, you see a mapping of social vulnerability index, or area deprivation index, area deprivation index in different neighborhoods. And kind of unsurprisingly, areas with higher deprivation index are more associated with gun violence. In fact, this study that was published today, like literally today, in the Annals of Internal Medicine, looked at the association between historical redlining policies and current non-suicide firearm fatalities. And what they found was neighborhoods back in 1937 that were more likely to be assigned a grade of hazardous had a much higher incidence rate ratio of non-suicide firearm fatality. So we see a correlation here from something going back literally almost a century ago, having enduring association today. Right? And this kind of puts a visual point on it. And so how do we begin to understand and probe how these associations take place beyond theoretical mechanisms? And so, we can look at it from geography, but the problem is when you have concentrated disadvantage in different neighborhoods, even down to the block level, it can be very difficult to distinguish then what is related specific to firearm violence and exposure compared to other factors related to poverty, particularly in city settings, though not exclusive to that. And so one emerging strategy for this is looking at agent-based modeling and other methods of being able to layer on different risk factors and to, at least from a modeling perspective, see how that might explain different variations or ways in which things can propagate forward. And so this is a newer approach, and really looking forward to some of the evidence that comes out from that. But beyond that, a lot of the studies really need to go back to the weapon and what distinguishes the way that weapon is accessed, the way that weapon is used, and the reasons for it, and how that then use of firearms then propagates into the community. So this study here, done in, I think it was 2019, was looking at firearm transitions, right? So this looked at persons who presented to the emergency department in healthcare settings with associated, substance use disorder, and assessed what their firearm weapon carrying status was, and looked at transitions to when they then went from not owning or carrying a firearm to when they began carrying it, right? And so some of the things here that fed into this was, yes, to some degree, substance use disorder, but more so prior victimization, gun violence victimization, right? So the injury itself becoming a prompt for increased weapon carrying or beginning to carry a weapon. And this goes back to that prior fact and observation before. If most people are not arrested for having committed a firearm crime that resulted in the injury of another person, well, then how does that victim then have the ability to guarantee their own safety if there is not a legal mechanism for doing so? And that may be owning a firearm. Well, what happens if that victim is an adolescent who is prohibited from carrying a weapon in the first place, or has other justice involvement that also prohibits them from carrying a weapon? How else are they going to protect themselves? Quite frankly, a lot of it comes down to retaliation, right, or escape. And this further complicates our ability to measure things, because then people either become very quickly at risk for re-injury, being involved in this cycle, or to being lost to follow-up, having left the area. And so how do we really measure these associations when we have persons that are at such high risk? And this is where doing qualitative research and phenomenologic studies is really, really key. And so this study done by Dr. Dorothy Dillard here in the state of Delaware, as well as several other cities, was really remarkable. This was done through the Thurgood Marshall College Fund, and really instrumentally done through the Center for Structural Equity in Wilmington. And what they found in this study was they went and they interviewed young African American men living in the city who were, by definition in this study, illegally carrying firearms, and asked them a bunch of questions and interviews about who they were as people, what were the influences that went into carrying weapons. And this kind of base statistic here is stunning and directly related. 94% had known those who had been shot, and 81% knew those that had been killed, right? And many of these were family members, and many of these incidents occurred before the person was 15 years of age, and up to a third of these before they were even 10 years of age, going back to the ACE observation that we saw locally in Wilmington City in that prior survey done before. And then you can also see some of the transition in feelings here, feeling sad, scared, hurt, and then over time, when these incidents recur in their social networks, angry, hurt, numb. The first age of exposure to these in terms of seeing or possessing a gun was also quite young. 44% were introduced to the gun by a parent. And in this study, 77% first possessed that weapon, again, not legally, between the ages of 10 and 15. And almost all of these contexts then received it through a relative or close friend. So again, this is either the straw purchases or transactions, private transactions that occur. There's even been what's described in like reporting as community guns, where there's a gun in a commonly accessible location, depending on which group may have access to it. And that the reaction to the possession of that gun helped them feel powerful and control and safe. And the key word there of safe being that the owning of that weapon in this population of persons who are prohibited from owning a firearm mirrors that of people who legitimately and legally own a firearm, which is for personal protection. And I want to recognize that the weapon carrying is the symptom of felt insecurity and lack of safety. Somewhat of the irony here is that those who possess firearms illegally for this purpose are the ones that are the highest risk of having that injury happen to them. So in terms of where did these persons learn how to use this from, one thing that was kind of stunning was the rate that learned how to use the firearm from YouTube itself, or from media or other social contexts. And again, one of the main reasons for continuing to possess owning the gun being for safety and protection, right? So now we're going to go into some of the biology as well as the clinical consequences of firearm ownership and injury here. So on a macro scale, what's the impact of gun injury on the survivors themselves? Increased rate of recidivism, as high as 16% in 10 years, or even up to 26% for certain subgroups, which is really stunning. So if you were injured by a firearm, your risk within the next 10 years of being injured again as high as 26% is shocking. Like if you walked in to the ER or emergency department with chest pain and had a heart attack, and someone told you your risk of having another heart attack is 26%, a potentially life-threatening and fatal complication, that would be stunning to you and maybe prompt a lot of research and intervention. Yet we find that to be the case here for firearms, with a lot less known about what those research and interventions may be. What we also know is that for those that are victims of firearm injury, compared to those with similarly severe injury, as graded by injury severity scale through trauma registries, firearm injuries are more associated with having pain, PTSD, and worse quality of life, even when controlled for the severity of injury, compared to a matched controlled set from, say, motor vehicle accidents by comparison. So why is that? So this study here in Health Affairs looking at firearm injuries in children and adolescents, this was a nationwide large study that was done looking at, I think, market scan data. And what they found was after the time of injury, the person that was injured had in the next couple of months increased care utilization for disorders related to pain, for psychiatric disturbances, and substance use disorder. And these are things that we've historically known to be associated. What they also did in the study is they looked at other members within the household and how did their utilization rates change after someone in their household was injured according to those same outcomes. And what they found was the other members in the household also tended to have more incidents of things like pain and psychiatric disorder as well in the months following injury, right? So there's this spillover effect that occurs even outside of the individual that's affected. And so we start getting into this conversation about what is the impact of gun violence then on communities. What's well known is hypervigilance, and how hypervigilance plus minus association with PTSD, so not necessarily related to a specific direct traumatic incident, but could be, is present for those with prior assault injury. We know that well for the literature on sexual assault. We know that to be true in the literature for those with gun violence assault. And we are now seeing this to be true for those that are exposed to police violence, though that can, again, be difficult to disentangle if part of the issue with gun violence being that it involves police and justice systems as well. That said, those who had community and police violence had increased rates of hypervigilance in a community setting. Moreover, older adults living in neighborhoods within these communities with high rates of violence exposure had increased rates of social isolation and loneliness, which we are now finding out from a separate body of literature on social isolation and loneliness being associated with worse physical and mental and emotional health outcomes as well. Some of the other spillover effects that occur here is when there is a homicide that occurs locally. In these measures and studies, primarily by Dr. Patrick Sharkey, looking at standardized testing that was occurring, they found that in the immediate several day or even week period following a firearm or a local homicide, that there was a measurable reduction in attention and impulse control and cognitive performance in standardized testing. Right. And so this, again, isn't just something that happens to the individual. It's something that happens on a community basis, though challenging to measure. And so I'm going to kind of fly through a number of different physical health outcomes that have been observed to be associated in study of youth based on this systematic review and augmented with a couple of studies seen more recently. And so this systematic review done in 2017 went through and said, what's the association with community violence exposure? So these kind of public incidents that happen commonly by firearms, though not exclusively, and the relationship to physical health. And they found the studies that have been done, not many of them, but the ones that were there, related to these main domains. One of them is asthma and respiratory health. And there have been a series of these studies done that found that there is a correlation between exposure to community violence and increased asthma risk. That said, the results have been mixed. And these were mainly retrospective studies that were done. And what they found was, for example, association with African-American race with asthma risk, but that association tended to disappear when you start controlling for other factors such as social determinants of health or collective efficacy, poverty, a rural versus urban environment. And this kind of goes back to those structurally violent situations that kind of set up someone for worse health outcomes, arguably in general. One may also think, well, the neighborhoods in which firearm violence happens is more commonly in urban settings. Urban settings also tend to have more people. There also tend to be more vehicles there. Therefore, there also tends to be more air pollution. Could that be the correlation? And some of the studies done here found that the levels of air pollution did not entirely explain these changes in asthma exacerbation and risk in respiratory health. So there is potentially some other dynamic that's here that is specific to firearm incident. And some of these were looking at temporal changes, where when there was an incident that happened in the community, they geomarked where it occurred, and they looked at the number of hospitalizations that occurred within a radius around that within a 30-day period afterwards, and found maybe an increased incidence of asthma exacerbations, but then also anxiety or panic disorder as well, and sometimes being difficult to tease apart the difference between asthma exacerbation and anxiety. So that gets a little bit challenging, and again, part of the reasons perhaps why there's mixed evidence, but to kind of drive the point home, there needs to be good accounting in studies of this, of the impact of these other environmental factors. And so this study here, looking at associations between emergency department and asthma visits with, for example, race and ethnicity, found that a lot of that was essentially explained or better explained by these other factors when you try to control for them. Problem is, a lot of our studies looking at this and the usual collection of health data does not account for these things. And so it's a thing that we can speculate as the reason for the correlation with race, but needs a lot more nuance and more specific, dedicated, purpose-driven experiments to test or at least examine that association. Cardiovascular health has been something that has been described, and increasingly so. And nearly all of the studies done in this show significant associations. Community violence exposure is happening, and then most commonly an increase in blood pressure, typically systolic and diastolic, and with effects that can be persistent. And for those that are familiar with the adverse child event literature, we know that those who have more exposure to childhood events, adverse childhood events, tend to have higher risk for cardiovascular outcomes, negative cardiovascular outcomes, for stroke as well. And this may be part of how that translates. Increased hypertension from essentially being exposed to these incidents, then leading to chronic hypertension over time, then leading to increased risk for cardiac and cardiac risk and stroke. And drilling down into this, the causal pathway seems more and more clear. So in some studies looking at specifically men who have high exposure, and we do know that firearm violence tends to affect men more than women. Association with daytime epinephrine and non-dipping status, meaning more persistently elevated blood pressures throughout time, and increased risk of developing future hypertension. That said, there is some differences in observations here. And so there were some studies that noted the people with the highest amount of exposure may have actually had less heart rate and blood pressure reactivity. And a study done locally here, looking at blood pressure in association with a wide variety of things, found that attitudes towards guns, positive attitudes towards guns as being protective, may have even moderated this association between the degree of violence exposure and both elevated systolic and diastolic pressure, i.e. something that could be a protective effect. Now, I think some of the question is that a protective effect, or is that because those that are the most exposed tend to be the most numbed? And in being numb to that, not just on an emotional level, but actually on a physiological reactivity level. And some of this may actually relate directly to immune functioning and the HPA, the hypothalamic pituitary axis. And so the HPA axis is moderated by a series of hormones and signaling that occurs between the brain, the adrenal glands, getting the adrenaline and the epinephrine going in the system. And we know that stress can stimulate this axis to act, but that chronic stress can actually suppress or blunt its activity or lead to hyperreactivity, paradoxically. And so we know that cumulative exposure to stress in general leads to attenuated responses as measured by cortisol, one of those hormones. And more specific literature that's coming out says that this attenuation and this cumulative exposure is pronounced, and perhaps even most pronounced, when it's related to violence. And so it may be that violence is a major explanatory factor in the way in which childhood or chronic exposure to stress influences this alteration of the immune system and HPA axis. Sleep is definitely affected by violence exposure. This is most readily recognized in PTSD, but there have been described impairments of sleep that occurred even without meeting criteria otherwise for PTSD. Some of these may improve with time, as with many symptoms after an acute stressor, but many of these can also be persistent. And we hope to have more detailed evidence about this in the years to come, now that the National Youth Risk Behavioral Survey has begun incorporating explicit questions related to exposure to violence and specifically community violence. And so in this recent study looking at that, it found that exposure to violence was associated with significantly higher odds of insufficient sleep in this nationwide sample. And then general health. And so previously, the thought has been that firearm violence and violence exposures in general are just part of the general strain that happens in communities where there is concentrated disadvantage, and that this being one of many factors there just adds stressors, but that the net effect of those stressors is what has impact on a person's general health. And so there is mixed association when we look at self-rated general health measures, but those mixed results are more in cross-sectional studies. And when we look at more of the longitudinal studies looking at, again, this relationship between violence exposures and general health, we do find a stronger and stronger association, perhaps even in dose-dependent fashion. And that these exposures may also be related to somatic or physical expression and manifestation of poor health, such as in children and adolescents, appetite problems, stomach ache, headache, though again, the findings are a bit mixed and heterogeneous there. And I think it's really important to say here that there's a problem inherently with sampling. And if we're talking about firearm violence, and we're talking about weapon carrying, and we're talking about involvement in networks and things like that, such as with gangs or with groups, there is inherently going to be closer association with justice and policing systems. And there are more studies that are being done from justice and policing systems and criminologic areas. And so what's out there in the published literature has this bias to it in terms of what's being put out there. And what we find then is that there then is this emphasis on male-only samples, and that this may then start skewing the literature. And so I think we need to be really careful about how we interpret these studies in terms of their generalizability and how that population was accessed in the first place. And so in my last maybe minute here, just real quick, say a local study that we had done, that I had been a part of here, looking at both a series of focus groups and looking at people's general health as it related to exposure to violence. And I'll just cut to the point here. And we found that those who were victimized as compared to those that mainly observed it happening, compared to those that were in the area in communities that were highly affected, when we look at their quality of life as a distal outcome measure, we find, yes, victims tend to have worse outcomes for health, but that it wasn't necessarily worse physical health. It was worse things like pain, general health, energy, isolation, socialization, emotional health, and that perhaps there actually is a dose-dependent factor going between those that are not victimized or those that are just in the community around it, as we move closer and closer towards direct observation and close network involvement with persons who are directly victimized. And so I'm pretty sure I'm out of time there. I have some excerpts there from our focus groups, and I'm just going to leave it on the slide here for you to read about, again, how some of these spillover effects may happen from an individual's experience with violence and then beyond. So I'll stop there and ask for questions.
Thank you so much, David, for this really enlightening presentation and, as always, very stimulating. Any question from the audience? I guess we are running a little out of time, but if you can, and do you have time, David, to answer questions? So if any questions?
Yes.
I have, oh, John, go ahead. You want to unmute yourself?
Just wondering if, in addition to the differences in coding over the years, do you find that the trend in nationwide reporting is starting to ease up, or are places still consistently, because of the pushback of reporting, are areas of the country still more reticent to report their data, or is that becoming more the norm across the country, that the data is more available?
That's a great question. So there's a couple of different silos to the data, and I'll see if I can kind of rewind here in slides. When we talk about that siloing effect, I don't have it explicitly depicted, but there is the like ED reporting, there's a trauma census, there's state level reporting. Now 48 states of the 50 contribute to the National Violent Death Reporting System. So for homicides and fatalities where that occurs, we have much better data and more granular. The problem is that most firearm injuries are not homicide. And so we're trying to extrapolate that based on injury data. And you're right, and this is exactly the topic of a research study that we'll be doing here over the next year, is looking into the ICD coding of it. The problem is most of the data is gathered from ICD coding, and within institutions and reporting to the national level, it's very inconsistent. And a lot of these are erroneously coded, where they're attributed to being an accidental injury as compared to an assault injury. The classic example here is someone that comes in as a gunshot wound and they says, oh, I was out on the street, I heard gunshots and I was injured. If one is not explicit in describing that as an assault category, clinical documentation coders are almost obligated with current regulations to code that as actually unintentional, meaning accidental. Even though the CDC's own description of what should qualify as an unintentional or accidental injury is much more strict. i.e. like cleaning a gun and it going off, or where the owner was known and then it was known to be accidental. And so we're hoping that by the end of the year, the CDC will actually, and Medicare will actually publish coding guidance to correct that, but that makes the data really difficult to interpret now. And so I think on a per institutional level, examining each institution's data will help to shine light onto those coding practices, what the true nature is of the data there. And when that's understood, then that can be generalized, or that can be then harmonized with other institutions. So that was a lot of me talking with that verbiage. I hope that made sense.
Yes.
Yeah, no. John? What anything?
No follow-up to that.
Mona Lisa has her answer. Would you like to
I have a question. I was just wondering, Dr. Chen, is there any research to show that some of this gun violence, I guess in Wilmington and maybe other cities, could be gang related? There's just so much of it going on, and I just wonder if it could be gangs.
So that's a fantastic question. And that's exactly, looking back, realized didn't really go into that. A lot of it, if not most of it, likely is gang related. Why do I say gang with quotes? The definition of gang has actually changed over the years to be more what we call group now. And so you may hear that term thrown out there, group related. Why is that important? You know, a lot of our prior conception of gangs, and that is likely the explanation for why it is densely network related, is these groups of association. We think about things like the Bloods and the Crips and these kind of national gangs. But really over the past 2 decades, really past decade, that's evolved to the point where a lot of the groups that are there are not part of like a national gang, or they may put out a name that they identify themselves with, but is not very distinguishable from a group of friends, right? And so there may be a group of friends that call themselves by something, but don't carry weapons, right? Aren't involved with violence. And there are groups that do, and then that leverage that as a way of protection. Now, that dynamic with gangs or groups is then what really gets into what is likely the driver of a lot of gun violence. And specific intervention that have been developed for this, the most, I think, well-known one is something called focused deterrence or group violence intervention. And that has been operative here in Delaware and Wilmington for the past several years. I didn't get a chance to go into the interventions as much, wanted to paint a broader picture here with this talk, but I'm happy to talk more about that as well. But the idea with that being that, yes, gang violence is likely explaining a large amount of it there, but the problem being is that social media conflicts and things like that can often escalate things rapidly, where you may have individuals or groups that themselves were not firearm carrying before that then quickly pick up or have access to the weapons because they are unfortunately very readily available in the city. And so that's where that dynamic is really important to understand, and yet really isn't understood, is the factors that lead people to having increased risk for carrying or picking up a firearm, the accessibility to that firearm, and then whether they go and use that firearm. Does that make sense?
Yes, thank you.
Thank you so much. Any other questions? Well, I have one, but I'd like to see if anyone. Right. So I think I read or I heard, I don't remember exactly, that the violent crimes had decreased in Wilmington this year, in the last couple of years. Was it? And I know many interventions had started after the CDC report. Was there at first, is it true? I'm not sure that this is absolutely, if
Yes.
my memory is good. And second, what was the intervention you think was the most efficient to do that?
Great question. And I guess I'm still being recorded, so I'm on record for this. So the answer is yes and no. It depends on which measure you're looking at. So if you look at the total number of victims of firearm violence, that number over the state has decreased. It has decreased more in, say, Kent County and Sussex County though that decreased the most in 2021, 2022. In Wilmington City specifically, the number of those that were injured by firearm assault in the city was actually the same in 2023 compared to 2022. However, the number of persons who died from firearm assault injury was less in 2023 compared to 2022. That last point is what you will hear described the most in the media and in reporting. They say, oh, look, the number of homicides has decreased. But if you drill down into it, the actual number of persons injured and incidents within the city has been actually kind of static between 2022 and 2023. I find that concerning because are we at kind of a baseline now for it? What were the reasons behind it? I think there have been a number of different interventions that have taken place. And I want to say that I do think that the changes, even that kind of reduction in homicide, is something worth celebrating, right? Fewer people who died from it. But the reason why is hard. I think it's easy for people to say, I want to take credit for this, right? But then when things go bad, they say, I don't want to take credit for that. And I do think it is a multifactorial thing. What we do know is that increased amounts of community-based organization engagement, after-school programming, schools, policing, and other things does decrease the amount of firearm violence that takes place within like local hotspots and communities. So the question is, how much of this is regression to mean, i.e. policing, schools, after-school programming now returning to pre-pandemic functionality and engagement, calls for service and all of that, as compared to specific directed other interventions on interfering with it. I'm sure the data exists, but a lot of it is fairly private, again, going back to the silo thing within, let's say, policing systems, healthcare systems, and such. I hope to hear more about that in the coming year.
Thank you. I think we take the last question. Christine, you have a question?
Yes, I do. Thank you, Dr. Chen. This was informational, a lot of information. My question is this. I know you mentioned that witnessed violence is, most people who have witnessed violence have some sort of, relationship to their future experiences. But what is the difference between watching it in the media and actually being there when it's actually happening? Because I remember like when we had the media with, I don't want to bring this up as much, but the Black Lives Matter, we had a lot of violence that was in the media, and we saw that, through the media, not actually experiencing it. What are the effects of this when you see it in the media versus seeing it actually happening?
That is a great question. Number one, seeing it in the media does have an impact. And there have been some increasing studies about this, whether witnessing increasingly graphic depictions of war, death, all of these very traumatic incidents, people do describe impaired well-being in longitudinal tracking of that. That, though, is distinct from what we're talking more about here in community violence exposures. This goes into kind of semantic definitions. When I talk about community violence exposures, older definitions included that media exposure, newer definitions do not. And they say there is a distinct effect from direct witnessing. The slide I have up here is from the study that we did in Wilmington and the analysis of it. And I'll just explain here the different bars. So that first category, me, that first line, fighting 20, is persons who themselves were in a fight. The second row, those persons who were severely injured, themselves stabbed, themselves shot. Then the line under that is those that observed a fight happening, those that observed someone seriously injured. The line under that is those that only heard about someone in a fight, serious injury, stabbing, shooting. And so this is how we try to get at that exact question, is what is the granularity? What's the impact of something like witnessing something? And what we're trying to do is essentially pattern detection, right? Is there a pattern to how people are exposed to violence that matters more? And what we found here is these four distinct groups. What you're describing is probably more similar to persons in bystander isolated, where they may have heard about fighting, right? Or a serious injury, or seen it, some fighting happen, but themselves were not directly there when an injury occurred, or were themselves not injured. And what we find again is, I think, a dose response, right? And so the closer one is to violent injury, the more close someone is in a network to violent injury, the more of an impact it has on them, right? And so if it was a family member or a close friend, has more of an impact than someone you only kind of heard about or knew in passing. But that thing happened to someone that you heard about or knew in passing still leaves an impact on you as well. Does that make sense? Does that answer the question?
Yes, it does. It does. Thank you.
Well, thank you again, and I'm sure we'll have you come back and give us some some results of your studies. We would love to hear those.
Yes. Next time. Sorry. Thank you.
Thanks again. Thank you, everyone.